Hi, I'm Matthew Hersberg, and this is the Myopia Mindset. This is your weekly check in for all things motivation, inspiration, and education on your path towards success with myopia management. And this is our regular monthly ongoing segment, Myopia News Monthly, with which I have on a panel of guests, and we break down some of the top stories that have happened within the last month in the myopia management industry. I'm a strong believer in that you should grow organically into the expert you were always meant to be. And a good way to make sure that you do that is to stay on top of what's happening in our industry. And as there's always something new happening in myopia, it can often get a tad overwhelming. And what better than to have on, clinicians, industry, academics to help us break down these important news stories as they happen. And with that, I'll go ahead and introduce my guest, my regular guest panelist, Dr. Andrew Brauer from the Eye Care Center of DuPage is here with us again. Welcome back, Andrew.
Thanks, Matt. Happy to be here. Always having a blast.
For sure. And my good friend, Dr. Priscilla Chang.
Thank you for having me.
All right. And also, if you're interested in more from the Myopia Mindset, myopiamindset.substack.com is where you go to support the show. We do weekly articles, we do weekly episodes, we do bonus content for our paid subscribers who, believe in myopia management or are looking to up their game, level up in myopia management. We're going to be covering 3 stories in this episode, and then we're going to have a 4th story that is going to be exclusive to our subscribers. It'll come out later this week. So if that appeals to you, check out myopiamindset.substack.com. All right, that's my spiel. Let's get rolling on the news stories. I'm going to read the abstract, and then I'm going to hand it over to you, Priscilla, for a more in-depth overview. From Optometry Times, at this year's AOA Optometries meeting, 2 leading experts highlighted both the complexity and urgency of modern myopia care. We're speaking about puzzling cases in myopia management, which examine challenging real world cases that often leave clinicians searching for answers, which share practical strategies for navigating difficult treatment decisions and translating science into clinical art. And then there was also high myopia consequences on the retina, which emphasized that high myopia is far more than a refractive error, detailing its association with myopic macular degeneration, peripheral retinal disease, glaucoma risk, and the critical role of advanced imaging in protecting long-term visual function. Together, these presentations reinforce a growing shift in eye care, moving beyond vision correction to proactively managing myopia as a lifelong ocular health condition. Priscilla, what can you tell us about these presentations?
Well, I think first off, it's incredible that myopia is highlighted at optometry's meeting. I think oftentimes we think of the AOA as more from the advocacy standpoint, and people do go to optometrist meeting for CE. But highlighting that not all myopia cases are created equal, I think is really, really important. And some of those challenging cases, we've all had it in clinic, right? Early onset myopia, high myopia, patients who continue to progress even if they're using evidence-based treatments. And I think the point of the article and the point of that talk was really talking about how do you take a stepwise and individualized approach, to really understanding what works for that patient. Of course, when we talk about how we measure success, the average practitioner may not have an optical biometer, but, there's a very strong emphasis that if you are being serious about myopia management, to purchase one of those, right? Because using axial length as a primary metric instead of relying on refractive alone helps us think about progression and treatment efficacy in a different way. And I think one of my favorite things that, Dr. Longji had mentioned was actually compliance. I think that's like oftentimes like when talking to doctors and the question comes up about progression. This is like truly I think a big challenge is doctors forget to ask about compliance and reinforce it, because you could have great treatment, but if your patient's not using it as intended, you're not going to see the outcomes. We like to think our patients are perfect. They're not. Just as all of us, we have our habits and things that we fall back on. But the example that was given about improper atropine use, a patient that would drop when the eyes are closed. So we all sometimes forget that patients don't know how to use eye drops, right? So some of these issues are a lot more common than we think. So overall, I think this article is great in reinforcing that myopia management can be a little bit more sophisticated than we may think and a little bit more nuanced. But at the end of the day, I think as a profession, our goal is to try to simplify myopia management so more doctors are feeling confident about treating it and more patients are benefiting from that conversation. But the reality is you are going to get a handful of those cases that are inherently more complex, and that's totally okay, right? That's where experience, collaboration, ongoing learning, connecting with others in this profession really help us manage some of these cases. But ultimately, we're pushing towards that, standard of care of offering myopia management and being active about it for our patients.
Hmm. Andrew, anything to add?
I wish I had anything to disagree with. Yeah, my take was very much the same. These are, two doctors highlighted that I have a ton of respect for. Dr. Michaud knows as much as anybody on an academic, granular level, and he is so good at simplifying, as you said, Priscilla. And um, at the end, he said he kind of summarized it. Um, don't wait. Myopia will evolve. Single vision glasses are sugar for diabetic patients and cigarettes for asthmatic patients. And,
Right.
we still have so many practitioners that are wait and see. Oh, they're -2, but let's see if it gets worse. Well, if they're -2 at 8, they're going to get worse. Single vision glasses are not just neutral; they are harmful. And I
Hmm.
think that's an important big picture thing to keep in mind. Um, Dr. Raffatari on the second one. So I went to school in Memphis as surely all the listeners know, the best school in the world. But Dr.
Please.
Raffatari practices in Memphis, and so I've had the good fortune to hear him several times over the years. And the kind of tying into what you said, Priscilla, you know, this is a person that we wouldn't historically expect to show up in this context, and that's what I think is actually really awesome. So Dr. Raffatari is brilliant, macular degeneration, diabetic retinopathy, retinal optometric specialist, and historically, myopia was something else. Myopia didn't show up in the retina specialty world, and now that we've got the retina specialists talking about myopia, everything is finally coming together where myopia isn't just these weird people off in this other meeting. This is mainstream. This is big deal. This is holistic, integration of everything that we've kind of always known should be integrated. Um, and so, yeah, it kind of feels like we've turned a corner with, these topics making it into the most major meetings that we've got and incorporating retina specialists who would typically, focus on more geriatric disease and things like that. And so, yeah, no, I'm more taking the big picture view that this is a great sign. Getting input at this meeting from these people, um, and yeah, would love to see more.
Yeah, very well said, both of you. I apologize for not saying up front that the puzzling cases of myopia management by Lajeet Michaud and high myopia's consequences on the retina by Dr. Mohammed Rafateri. Um, I guess I'm going to be the dissenter in this conversation. So I do want to preface: I'm not an optometrist. I do not. I have not seen patients clinically. I grew up as a staff member. I guess the closest thing I would be considered is a myopia coordinator. I have had a lot of presence in this industry and have worked with a lot of optometrists doing myopia management at all different levels. And, as far as the first presentation, the puzzling cases, absolutely loved it. I love hearing Lanji speak, and take the opportunity to definitely do it in person at Vision by Design, for instance. It's the second presentation or the second piece, and I'll link to this in the show notes that I really have issue with, and I hope I'm not out of turn here because I know that these individuals are spoken with with reverence, but I kind of found the second one to be a bit offensive, to be perfectly honest.
Let's hear it.
And okay, so uh, it's specifically around the part that mentioned high myopia is far more than a refractive error. And it's like, but what about everything that's not high myopia? Like, the part I
It's a good
pulled
point.
from it was he stressed that high myopia, typically defined as greater than 6 diopters of myopia, should not be viewed merely as a refractive error requiring stronger glasses. Instead, it represents a spectrum of conditions that confer a significant risk of structural retinal and optical nerve pathology. And it's like, why can't we do this for all myopia? Like, essentially, like, we're identifying high myopia as a disease and no longer a refractive error, as a disease state. But what about the rest of it? Like, why is it just high myopia and not all myopia? Why would we be encouraging optometrists to wait until their patients reach a -6 in order, you know what I mean? Like, that seems really strange to me, and I'm wondering, like, why that is, because essentially he is saying, by implication, he's essentially saying that myopia, as long as it's less than -6, is still a refractive error, which is the part that I find offensive. Like, and hopefully I'm not digging myself an early grave by saying this. Listeners, by all means, send me an email about it, myopiamindset@gmail.com. But am I am I off my wagon on this, or like, am I crazy here? Like, what, what's the controversy here?
I don't think there's a controversy. I just think that from the research standpoint, how we've defined high myopia and from like our ICD-10 codes, like everything about how we define high myopia has traditionally been a -5 or a -6 diopters of myopia. So, to have a practitioner kind of call that out and be like, hey, just a reminder, a -6 is not just a refractive error. These are patients with significant risk factors of developing myopic, macular degeneration, peripheral retinal disease, increased risk of retinal tears. But I totally get where you're going. And I think that is where our profession is moving towards, is that all levels of myopia is unsafe. But I don't think necessarily it's a hot take or it's a challenge. I think it's just, you know, he happened to focus on that as a topic, I think, for the
Mhm.
talk. But I think the takeaway is that you have these patients who are higher risk and they require a little bit more thoughtful and comprehensive monitoring. Not saying that we don't do the same with our low myopes. But when you have a patient who's a -6, they're more likely to present with a much longer eyeball, and structurally things in the retina, things like the optic nerve, things look tilted. So it's a little bit harder for us to monitor whether this patient has glaucoma or they just have a myopic looking eye, right? And so I think, as a category, that's just kind of how we've looked at it as a profession, but not saying that we disregard those that have less than a -6 diopter of myopia. What do you think,
Yeah.
Andrew?
Yeah, I mean, I wasn't particularly offended by that just because I think, um, it kind of, don't let the enemy of good be perfect, I guess. And so, yeah, I view it as a positive that we're bringing more people along, with the general message, and I think that will continue to evolve. Um, I mean, certainly someone that, all of us know and I think respect a lot, Justin Kwan, I've heard many times say, something to the effect of, one of our biggest goals is to get kids to graduate high school with -3 or less. And, I think that's a great perspective, but, I mean, even to that, you could say the same thing. Well, why don't we want them to graduate with -1 or less, or plain or less? I wouldn't nitpick at that, and I think even, even the premise, um, has a little bit of a problem to it with, again, does that -6 patient have a 23.5 axial length, or do they have a 26.5? And, probably more likely the second one, but there's no guarantee of that, and so, um, yeah, no, I see it as progress. I like the way you think. You've got a little chip on your shoulder there, Matt,
A little bit,
but,
yeah.
yeah, no, I think it's a great point. I think it's a great interpretation. I wasn't quite so hard on it, but, no, it's a great point.
But I think that's a very astute observation, actually, because I feel like there is still a significant portion of our colleagues who wait until a high myope before they're actually kind of concerned. There's still a significant portion of them that are going to wait for progression to happen in order to start having the conversation because they think it's an easier sell or easier conversion for the patient. But all of these patients deserve to know that myopia is a disease. It's been recategorized. You know, we have so many places to direct them, including the
Right.
National Academies of Science, Engineering, and Medicine. Like, the way we're thinking about it is different, and we're not just prescribing lenses for myopia management, right? We're thinking about how do we prevent future retina consults? Because I think the other alternative is that when you're talking to primary care doctors, they're like, well, I don't see the myopic macular degeneration in clinic. I don't see the peripheral retinal disease. So I don't think that the things that you're telling us is actually happening. And,
Mhm.
when I talk to them, I'm like, well, we see the trends happening in Asia. We are trickling behind in the US, but it's significant enough that, like, Andrew was saying, like, you have retina specialists coming out, kind of ringing the alarm bells out there. But in the US, it's a much slower adoption of that kind of narrative because, they have those patients coming in, but oftentimes it's like they're busy seeing those patients. They're not taking a step back and being like, let me go out and tell people that this is what I'm seeing in clinic. So your average primary care doctor may think that because they're not seeing it, it's not true. But you have, lecturers and, people coming out and being like, hey, this is actually happening. We're seeing these structural changes in these highly myopic eyes. And, we really need to be having these conversations much earlier. So that's kind of, I think, the spin that I look at this, article from.
Yeah, like, I wanna be absolutely clear that any kind of spotlight on myopia in whatever form is valuable, and this is not an attack against any specific individual, and the chip on my shoulder that Andrew is mentioning is definitely there, and it's there because when I first started in this industry, working for the AAOMC, which back then was the Orthokeratology Academy of America. And it's like I would work booths and try to talk to optometrists all the time. And they like were very explicit in what they thought of what we were doing as like snake oil and how dare you do this to children. And myopia it's a refractive error, like or it's all genetic, right? And I feel like we need to like rip off this band-aid and be like, this is a disease. This is a disease state. And we cannot give optometrists permission to let this get worse. Like, how many things have we seen or heard or read online? I'm thinking of like the stuff we see on social media with these parents who are like, I've been taking my kid in to see different optometrists, and they keep telling me, like, your kid's eyes will just get worse and there's nothing we can do about it. And some of these kids got to a -6 before they finally found someone to do something about it. And I guess, like, I equate this to any other kind of healthcare, right? If I went into a doctor and the doctor was like, "Oh, by the way, you had this thing, hypertension or whatever, um, and, like, I didn't really tell you about it because I didn't feel like I had to. I waited until you got to this point, and now we should do something about it." Like, I mean, my pedigree comes from Carrie Herzberg, obviously. I believe in preventative care. That's how we did things at Herzberg Optical. And I feel like this is kind of a stab in the back to that idea of preventative care. It's like, what is the harm in identifying all myopia as a progressive disease state? Like, somebody tell me why we can't do this. Is it because then optometry has to like belly up to the bar and be like, we used to call it a refractive error and now we can't do that? And maybe that's viewed as being neglectful, but isn't it neglectful to let a patient get to -6 before you start taking myopia seriously, which is the unfortunate circumstance that a lot of patients find themselves in? And I've met and heard from these desperate bereaved parents about this state. That's my soapbox. What do you guys
No,
think?
hard to argue that. Hard to argue that. And I mean, just to be clear, I mean, nobody on this webinar is, taking exactly the same stance as, anyone else did, but yeah, no, I think there's a lot of sense in that.
Okay.
And I would say that I think there's two sides to the story, maybe even three sides. Like, I was in clinic and I remember I had a patient who was -8, and I told, I was talking to this patient about myopia management. He was all on and ready. Next lane, mom was in that room. I went in and tell her, like, hey, we discussed this. This is the challenge. Hey, mom, like, are we willing to start treatment today? And she just looked at me and was like, no. And I was like, where did I drop the ball? And, she just said, I want my kid to qualify for medically necessary contact lenses.
Uh,
And I want to wait for them to get to a -10. And I mean,
uh,
I felt like my heart dropped, but I spent so much time trying to be like, okay, can I educate you beyond like this perception that you have? And I think this is where the Myopia Collective is really important because we need that public awareness, right? We need doctors to be having those conversations. And, I truly think the best form of advocacy is telling any patient, right? Not just those who are myopic, not just those who are pregnant with a myopic child, you could talk about it with those who are coming in for cataract surgery and just be like, hey, did you know like your prescription's, significantly high? We could do something about this if you know someone in your life. Myopia management exists, right? Like just a quick little spiel about myopia management is like so, so important because there
Right.
is the lack of public awareness that makes it also challenging. Of course, when you go on the Facebook forums, you're going to get all the angry parents because they happen to be surrounding themselves in this echo chamber of other parents who care. And that's
Mhm.
where I think it is really sad sometimes to see that as a practitioner, that many doctors have maybe let these patients go. And these patients are going to the internet to ask for help or to be like, hey, read this prescription, tell me what treatment I need. That's a huge misstep and missed opportunity for our profession. And I always encourage our new grads, even students, to start subscribing and joining these Facebook groups because I'm like, it's going to help you be such a better communicator when you realize what's not being said.
Right.
Oftentimes, the parents are just nodding, kids are not. They're just trying to get out, right? Like they're trying to go to the next thing, and we really need to spend that just extra 10 seconds or whatever talking about myopia management so that, that scenario that I had with that patient or that mom where I'm like, oh my gosh, like the kid gets it, like you don't get it, right? And
Right.
what actually ended up happening was that kid ended up taking on internship jobs and things like that and came back like a year later and was like, I saved up enough money for my first year
Wow.
of my site. And I was like, oh my
Wow.
gosh, like that's crazy when the patient has to be the one to advocate for themselves. And I think that's where we have to think about how do we help guide the conversation year after year, or don't let them go for a year, right? To really emphasize the importance of that follow up and just kind of shift the mindset. I think a lot of doctors still think, again, I don't see those high myopes. So I don't think it's as big of a problem. I think that if I don't sell glasses, I'm losing out, right, on this
Mhm.
patient. But really, I think the revenue per hour increase, a lot if you're doing myopia management. This can help with the sustainability of being in private practice and things like that. So I think it is a paradigm shift in how we're thinking. I don't think people are necessarily thinking about how they're throwing themselves under the bus. But oftentimes when I coach doctors, I'm like, hey, there's just been a shift in our profession. We know better to do better now, and so let's kind of have those conversations with our patients and admit that we didn't maybe know everything a year or two ago when they last came in. And
Right.
we're not throwing anyone under the bus. It's just we know to do better now. And so why aren't we doing it? Right. So just really emphasizing that.
Yeah.
Yeah.
And go ahead, Andrew. Go
Oh,
ahead.
the only thing I was going to say, so maybe this merges the two worlds. I don't know, but I really like reframing. I really like stepping back and how can we think about this a little bit differently. And so I would say to the docs out there that um, for whatever reason are stuck on that -6 number and that's their focus. I'm reminded of Priscilla, one of your neighbors out west is Dr. Aller. One of the things he's been saying for years and years, for perspective, is that you know if you want to keep kids under a -6, but you start when they're a -50, you only need like 20% control, and you're going to achieve that goal. If you wait until they're -5, well, now you need pretty darn close to 100% control, and you're never going to get that. And so, even if let's say you don't care about a -3 or -4, even if you care about a -6 and that's your cutoff, start now. You will make it possible, and not only possible, but easier on yourself. The sooner you start, the lower the threshold becomes and the more achievable it all becomes no matter what your goal is. So it really leads us right back to start as soon as you can. Don't wait, don't watch. They're going to get worse. Give yourself every chance to be successful. And, regardless of what your target is, there's never a good time to wait.
Right. And that's very well said, both of you. And, Priscilla, in your example, it's heartbreaking to hear that the mother,
Oh, that was brutal.
said
Yeah.
that. Um, but that was her choice, right? Like, I worked on parents for 5 years on average growing up as a snot-nosed kid in my parents' practice, and we're just prepared to hear no from the parents that this year, this just wasn't something they were interested in, and there's 101 different reasons why they wouldn't have done it. But we knew to keep the message going because that's what our data showed us, that eventually, on average, within 5 years or at 5 years, that's when we would see the conversion. But the important thing is that that was the parents' decision. And I am a huge fan of the Myopia Collective. I think it's a brilliant move. I think it's exactly what we need in our industry. I just don't. I just don't want this conflicting messaging. I want clear, consistent messaging. Like, in my opinion, we should be acting proactively. We should be preventing myopia in any way, shape, or form, as long as the parent is on board with it and the kid will do the treatment. What's the problem? And I feel like this is mixed messaging by saying, well, -6 is a disease state. Anything less than that is still a refractive error. It's like this industry over the last 20 years that I've been in it, I have watched it shoot itself in the foot over and over and over again on a variety of different ways. And I feel like this is yet another load the gun, point it at the foot, and fire away. Because it's like, why can't we just say all myopia? You know, no degree of myopia is safe. Flitcroft, Bullimore, Brennan, what other, many others. Like, what else do we need to make this happen?
I think a lot of it is also confirmation bias because I realize when I go present across the nation at events, and sometimes doctors are just like, well, I'm a -4 and I haven't had an issue. And I'm like, you've just been
Sure.
lucky,
Yeah.
like,
Yeah.
and I think there's a lot of that kind of a mindset where if it hasn't happened to me, it, like, again, isn't as serious maybe as it probably sounds when someone is lecturing it on the podium or when an organization makes a standard of care statement. From my experience being in industry is every doctor has their own standard of care. And
Mhm.
national organizations will say, we have the standard of care. Everybody, please adopt it. Please adopt it. Science happens. I was talking to Kate Gifford and she's like, it takes 17 years for something to truly be ruled out as standard of care. So it just depends on when did we start talking about it? What do we count as day zero of that 17-year cycle for when we think the entire profession is going to stand behind it? But I think consistently what I notice, and this is the reason why Cooper Vision even shows up at some of the more local meetings, is that, doctors, maybe they themselves have been really lucky, but their kid is getting glasses for the first time at a much younger age. And now suddenly they're interested. So I do think, like, not that as a profession we have trouble calling all levels of myopia as a disease, but I think there's a significant enough majority that are still resistant to accepting the fact that they themselves have myopia and that it
Right.
is being categorized as a disease. So we're kind of in denial.
Right, and it's that state of denial because I hear this as well. I've heard it from in the public sector. Like, I've gotten comments on my YouTube and on my Substack specifically. One just happened recently where it's like, what's wrong with moderate myopia? I'm an adult. I'm doing just fine. I'm a -375. And I'm like, wait a minute. My wife is a -375. She needs glasses to drive. She needs glasses or contacts in order to see the face of our child. like this is not acceptable to me. But if it's acceptable to you, so be it. You're a grown adult. You grew up in a different era. Screen time is now, they're saying that there's like 2 hours of screen time on average for kids before they even reach age 3, if I'm not mistaken. 8 hours of screen time now is projected for teens. It's like it's a different thing now. If you're an adult with moderate myopia, that's a completely different thing, in my opinion, than what we need to be messaging for the children of the future. Because, like, there's that story of that Texas ophthalmologist who was explaining the risks of retinal detachment to a mom in her 20s about her kid, and then discovered that the mom has a retinal detachment in each eye and she's in her 20s. So it's like, I don't know. Like, I think this is a failing of the industry as a whole, of optometry as a whole. Now, granted, take that for what it is. I'm not an optometrist. Like, but anyway, that's my spiel.
I would say, I mean, you're right. There's all these leaders saying this, but I would say in the academic space, I think it's still considered a hot take. Like, there's still a lot of
Mhm.
practitioners who are just like, again, it's not that big of a deal, right?
Right.
There are things that can be done. And I think that's where, when I lecture, I always am like, okay, let's think about myopic maculopathy and like kind of sit with that because, the risks of developing that significantly increases after -3, as Dr. Kwan has alluded to. But what does it look like to have that kind of a vision, right? Because we always think, I mean, it's really interesting. I think from the research standpoint is like parents can't like like it just doesn't feel familiar that their kid has these increased risks because they just think things are going to happen when the kid is older. Is not my problem at that time point, right? It's so distant, right? So it's similar to like I think money, where it's like, oh, once you hit like a billion, like no one really understands how much money that it actually is, right? So the increment of change, I think, is hard for people to understand. But I think for a lot of parents, it's like, well, my immediate problem is my kid needs to be fed. They have these like they think
Yeah.
about immediate problem and less so about the preventative side. So I don't think it's necessarily our industry, but I think it's healthcare as a whole, right? In the US, where we're not as focused on preventative care, and myopia management is all about that early intervention and preventative care, right?
Right.
So again, we have to shift the entire healthcare conversation to look at that from that perspective.
Yeah. Well said. Andrew, anything else to add before we move on to the next story?
Um, I think the ship has sailed, and it's a missed opportunity. But years ago, I was really hoping that we would come up with just a different term. Let
Mm,
myopia be the refractive thing, and come up with axial hyperopathy or something like that. And
mm,
once that kid has more than a 23.5 axial length, they've got this other condition, and just leave the refraction out of it. Let it be unrelated. Let it be correlated, but not the same. And I obviously we didn't go that route, and I think it's probably too late for that.
mm.
But yeah, I think there's always going to be some confusion, especially among non-pediatric docs, non eye care specialists, about just the terminology. So
Right.
how do you fix that? Basically, everything that we're trying to do, and increase awareness. But yeah, in my mind, there are actually some really unique differences between the two, where maybe they shouldn't even be the same term.
Yeah.
I mean, maybe my hot take is I don't think it needed another term.
Good.
Yeah, my hot take. But I would say, because I think with axial length as a profession, we've also, I feel like when I talk to doctors, a lot of them have been trained to look at 26 millimeters and higher as the risk factors of having some of those things. But when you actually look at the paper looking at axial length, right, it's always a distribution. And I think that's another thing too, is like as a profession, we get so held up on 26, but you have patients who are 22 millimeters with peripheral changes, right? You have this, again, distribution of axial length where we still have some of those retinal concerns. And so I think as it stands, we do have like myopia needs its own PR crew, right? Like we really need to rebrand it. But I do think that if there's already familiarity of a term, let's not overcomplicate it.
Hmm.
Let's have more people just truly understand what it means and the weight of having myopia.
Yeah. Yeah. Well, listener, if you have your own hot take on this, be sure to let us know. You can leave it in the
Mhm.
comments on Substack or wherever you found this. Or you can contact the show directly, myopiamindset@gmail.com, and come participate on on the Substack. We have a growing community, myopiamindset.substack.com. All right, let's go to our next news story. Andrew, I'm going to turn this one over to you after I read the abstract, which is: a newly published randomized clinical trial in Frontiers in Pediatrics examined whether combining 0.01% atropine with orthokeratology lenses can improve myopia control outcomes compared with orthokeratology alone. Led by Ying Wan and colleagues, the 2-year study evaluated both the efficacy and safety of this increasingly popular combination therapy approach. As clinicians continue searching for strategies to better manage fast progressors and higher risk patients, the findings add to the growing body of evidence exploring whether combining established treatments can produce additive benefits in slowing myopia progression and axial elongation. Andrew, what can you tell us about this article?
Yeah, I mean, none of us have time to read everything that comes across, and gets published. But this is one of those articles where I think if you just read the headline, if you just read the abstract, you're going to miss a lot. So, I mean, yes, we know combo therapy is safe. Yes, we know it's effective. But what I actually thought was really pretty interesting. I mean, we know that humans are adaptable. Humans that are the most successful species on Earth because we adapt. But this concept of adaptation kind of plays into this article. This, along with many other papers that have come out, show that the strongest myopia control effect is in that first 6 months, and then it kind of tapers off a little bit. Um, and then similarly, the strongest effect that we had here were in kids under 10. And so when we combine those two concepts, it raises a lot of questions. Right now, most doctors who prescribe atropine start the drops, and then it's just on cruise control. And you say you're going to be on these drops for years. I think probably in the future we'll move away from that. I think we're going to be moving, away from the cruise control and towards a pulse therapy. Maybe we do atropine like a steroid dose pack now. We start with a high dose. We step that down over the course of 3 months, 6 months, who knows? Give them 6 months off of the drops and then start it all again at the top of the year. Um, between what we talked about last time, where we know now that definitively tapering atropine is beneficial, and now we know that using atropine is most effective right after you start it. Well, the natural thing would be to combine those two concepts, and that leads us in the opposite direction of putting on someone on atropine forever. Um, and
I
so,
actually thought the specific paper was different from what you had said about the 6 month having the most, usually where we see the treatment effect for atropine, the most kind of concentrated within the first 6 month. I think this paper was actually very surprising because the first 6 month, it was actually not beneficial. So it's not clinically significant or not statistically significant for their p-value. And it also wasn't statistically significant at 12 months. So I remember writing it down because I was like, oh, this is interesting because the take on this paper was actually it takes 18 months to be clinically significant, or I guess statistically significant, sorry. And then it's strengthened at 24 months. So it was more of a cumulative treatment effect in this specific cohort in China. And I think that was very interesting. So it's not that, hey, if you're adding atropine to ortho-K, don't judge it at 6 months. You got to do it for at least 2 years. So I think it's just been different from some of those combo papers that we've seen and those findings coming out of those.
now I believe I'll have to double check this, so uh, don't take this for fact, but I believe that was in the 10 years old and plus group. I think the 8 to 10 group still did much better, 6 months, 12 months. And it was just that the older kids, it took long enough to get a cumulative benefit that was statistically significant. But you actually bring up a great point that I missed talking about with Dr. Michaud from the very first. He made a good point that I had not spent a lot of time thinking about, and that is just the nature of time, like you just said. And, I think we get trapped into thinking this is an on-off switch where you start treatment and growth stops, and that's just not how it works. If you evaluate your treatment too quickly, you might miss something that's actually working and is not just fully kicked in yet, essentially. So I actually think that's a great point by you, Priscilla. That is something that I probably need to spend more time thinking about. Clinically, how do we want to approach that? Um, because yes, there's a problem with waiting too long, but there's probably a problem with assessing too quickly and deciding whether something's working too quickly. So yeah, I think that's a great point.
Absolutely. Yeah, I think so many doctors, they assess within the first it's like, again, all of our sales reps usually funnel their questions to me or someone else on the team, and they're like, "Doctor tried this for a few months, and then there is progression, like, what do we do? The product's not working, or the contact lens is not working." And I'm like, let's revisit, right? Compliance, lifestyle, all these other things that can impact. It's not just, hey, this it's not like, diabetes, you take the pill and everything is good, right? We got to still manage the holistic picture, right? And I think that goes back to, some of those takeaways from the first article where we got to customize our approach, but think about it differently per patient. But, I think for this specific paper, I think is really interesting was that there was a lack of significance at 6 to 12 months, but when they did a subgroup analysis looking at the treatment effect, there was a significant treatment effect for those who were 8 to 10 years old at that 24-month mark. And for those that were 10 to 12, there was no significant difference, right? And then you also brought it with the lower levels of myopia, -1 to -3. There was a significant benefit at 24 months. For moderate myopia, a little less so, our -3 to our -6. So I think a lot of these findings, it's very easy for us to just, again, apply something, but we have to be a little bit, I think, as a profession, more critical sometimes when a paper comes out and then there's this headline, like, because again, we start shifting how we think and then we overcomplicate it. So I think there's definitely that importance, like you mentioned, of time, but also looking at kind of case by case, right? So like specifically for this paper, it's just like, well, there's a sweet spot for combo therapy, which I'm like, okay, that's important to know because I think combo therapy is definitely overused in our profession. And I think, you have that patient in front of you. They're desperate, right? They're a -3, -4. and you're like, I'm gonna throw the kitchen sink at it. So I'm just gonna do everything. But then I think the challenge that arises out of that is that how do you then distinguish which one is effective and which one may not be? And I think this paper kind of helps call that out as well, is that, there may be a specific type of profile where atropine with ortho-K is effective for long-term progression. Whereas, when you have patients that are older with more moderate levels of myopia, maybe ortho-K has already done most of that heavy lifting. So why put that burden on the patient to add on an additional drop on top of that?
Yeah. Well said. There's so many things that caught my
Very well
ear from
said.
what both of you said. Um, Priscilla, I think you made a great point about like the relevance essentially of combination therapy when monotherapy should be implemented. And I do have some questions I want to ask both of you as a panel, but like to kind of like piggyback on what you said, Priscilla, like are we looking at a point where combination therapy is outside of the advanced specialist? Because that's kind of how I view it. Is like we're having problems. I brought this up before, but like we're having problems getting ODs to start doing myopia management, let alone combination therapy. And I feel like combination therapy in the future is going to be the domain of the specialist. Like, that's gonna be how they define themselves as the specialist. Is like, isn't it more important to just, stick with ortho-K or MiSight or glasses or whatever, and not necessarily worry about doing combination therapy? Like, is this just are we just kind of spinning our wheels with combination therapy for the vast majority of optometrists who wanna do myopia management?
Well, my hot take is I don't think this should just be a specialist thing. I think every doctor is capable of understanding when to utilize a pharmaceutical because atropine is not without side effects. I think in this
Mhm.
specific study, they were trying to highlight that it had an excellent safety profile, but I think it's already flawed to begin with because if your placebo group has to use artificial tears, and we know kids should not be using artificial tears to begin with. They should have had a third arm that was just ortho-K, right? Like, or just atropine. So you're actually comparing apples to apples here. But I think in this specific study, that wasn't the case. So I do think that again, primary care doctors should be capable of using combo. I think as a profession, we should hesitate to start with combo though. Like we really should be giving treatment time, like Andrew had said, to assess whether or not it's working because like I said, atropine is it's not without side effects, right? It's a muscarinic and, antagonist. You're gonna have dry eyes related to this, right? Because atropine is going to inhibit the tear production coming out of the lacrimal glands. Yes, we're using super, super small dilute, like 0.01%, but ultimately that pathway is still muscarinic dependent, so it's like we're still like intervening somewhere with a pharmaceutical and we're having patients pay out of pocket for it because we do not have an FDA approved option. Everything is coming through compounding pharmacy. So again, there is an economic burden of someone having to pay for the drop, but on top of that, you have to think about some of those side effects, right? In this study, they used 0.01% and they found that they're like, well, there was a slight decline in, tear breakup time in the group that was using atropine plus ortho-K, but not in the ortho-K group at the 24-month um, time period, but it wasn't statistically significant. But that brings back to the flawed thinking, right? Because your placebo group was still getting an artificial tear essentially, right? So your comparison is not at the baseline of someone who isn't wearing anything on their eye, right? Or not using any artificial tears. And so there's definitely a ceiling effect that we're going to see for some of those side effects. So I think that's where it's really important for us to look at or scrutinize some of these papers sometimes because again, like Andrew's saying, no one has the time to really dive in and read this. And I think that's where industry sometimes we do spend a little bit more time reading some of this. So like lean on us for some of those, insights because, if this is our specialty and we go around educating across the country on some of these things, we are spending that extra time to really kind of dive in and really understand it because the average practitioner we know does not have that time. So we want to be that educational conduit to be able to help translate the science into clinical knowledge. And this is, a prime example of it, right? Where we're calling out there's little nuances in even this paper being the first one, but we there's still so much we don't know. And I think in the myopia space, the more you spend in it, the more you realize that there's still so much to learn.
Yeah, well said. Andrew, anything to add before we move on to the next topic?
And just that, every case should be individual. And, I think that, every kid's different. Sometimes combo is the right answer. Sometimes it's not. I do tend to agree that, well, I absolutely agree that starting with a combo is probably not the right move for almost everybody.
Right.
When we look to other clinical areas, I think certainly my view and the view of I think most people is, I would not start a new glaucoma patient on a combo medication because, again, if you get them two medications and you get an effect, you don't know which one's working. Is it both? Is it one or the other? And now that patient is on that for potentially years or forever, and you can't even say with any confidence that it's doing something. And I do think that's a problem. So I'm not against combo therapy. I think it has a really useful place, and we'll only learn how to use it better and more effectively. But yeah, no, I'm with you 100%. Don't start with it unless you have a really unusual situation.
Yeah. I've 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 watched, I've watched ECPs get befuddled around like monotherapy. Like, oh, I've got a patient, I should do something about it. Should I do my site or ortho K? Well, if my site's going to do it, do my site, like go for it. Well, what about ortho K? Well, are you prepared to do ortho K? Well, no, I mean, I have a topographer, but I really don't have any experience with it. And I haven't done any ortho K cases and I'm really not ready for it. It's like, well, then do my site. Like if my site will do the job, get it done. So it's like, I love the idea of combination therapy. I want to explore it more and more. That's why I keep putting it in our episodes here because I think there is an element of it that is in the future, is in our future. But like, I feel like we got a bigger problem in front of us, which is like, educate, get doctors off the sideline, getting them use the monotherapy treatments that we already have. We don't necessarily need to start combination therapy. Uh, all right, Priscilla, anything else?
I was gonna add another thing. I think,
Go for
a
it.
lot of these atropine studies or a lot of these combo, like, studies, it's like, it's great to see the treatment effect, right? At some point, it's gonna be maybe clinically significant because 'cause we're publishing it, but I think oftentimes is there's no rebound data at all, and I think that's where, for me as a clinician, I also hesitate, when I think about some of those cases where I'm like, "Well, I like knowing that, we are not gonna lose the savings that we got," right? So, again, like we need to give ourselves that time to understand the treatment efficacy, whether or not it's waning over time, but also like what does that rebound look like? And a lot of these studies are coming out of China, right? So you have
Mhm.
patients that if are not Chinese, we really don't know what's going on, right? Because there's some uncertainty around the generalizability of the findings from the paper or whatnot. So I think yeah, so I think that those are the things that, as I'm thinking about this paper, when I think about combination, is that we have overutilized, I think, atropine too, because at the end of the
Mm.
day, your patients who are using atropine need vision correction, and we have other treatment options that offers vision correction and myopia management. So why are we not leaning as heavily into that? And, I've talked to a lot of doctors, and sometimes they tell me it's because they feel more of a doctor because they're prescribing a drop that they need to go to a pharmacy for. And I'm like, that should not be
Mm.
what's, guiding your decision tree on like, which treatment option you should be picking. It really comes down to lifestyle and what does it look like for the patient, right? Because if you're starting them on just atropine, you're still going to need vision correction unless you're using it for pre-myopes. But like, I feel like that as a category is also something I think that's an observation that I've made, I guess, being in industry and talking to a lot of doctors.
Right on. Okay. And listener, if you're using combination therapy, let us know. If you're sticking with monotherapy, what is your position on atropine? What are you using in your practice? Are you using MySight? Are you using atropine glasses or orthokeratology? Let us know in the comments or on our Substack. All right, let's move on to our next story. Andrew, I'll hand this one over to you after I read the abstract. One of the most interesting technological launches was highlighted this month with the introduction of MetaWorks AL551 automatic optical biometer, with Grafton Optical named the exclusive UK distributor. What makes this device noteworthy is its ability to combine axial length biometry and corneal topography in a single automated platform, allowing practitioners to collect the key measurements needed for both myopia management and orthokeratology in one capture. The launch reflects a broader trend occurring across the profession, the transition from refractive error alone to axial length as the primary metric for monitoring myopia progression and treatment effectiveness. As more practices adopt evidence based myopia management, technologies that make axial length measurement more accessible, efficient, and repeatable may help accelerate this as the standard of care. Andrew, what can you tell us about this announcement?
Yeah, basically the last part is the bottom line. The more practices have this, the better. Um, you know, the more practices that can measure axial length quickly and easily in their normal workflow, without a burden, without having to think about it, the more this is going to become mainstream, the more that everyone is going to benefit from it. And so, is this particular instrument God's gift to myopia? Probably not, but you know, it's another really nice thing to see. Obviously we already have similar combo units, so it's not the first of its kind or anything like that. Um, but the more we get, the better. Put this in every office, make it faster, make it easier, make it um, reliable, obviously, and the more it can be an afterthought. Oh, we're just going to get that data. We're not even going to think about it. The better everything is going to be. So yeah, I'm happy to see anything like this come across.
Well, I appreciate looking at the picture that it looked like it has smaller footprint. I mean, you and me know, like we've helped a lot
Hmm.
of doctors acquire some of those combo equipments and just, like Andrew, we just want people to be using it, right? But sometimes the instruments take up a lot of room and, there's a lot of offices where their pre-testing area is already filled with all the other devices. So I think there is a need for more, instrument companies to come into the space to continue to push, I guess, that level of how do we better integrate into the workflow for the doctor, but how do we also like come up with technology that doesn't require a lot of space, right? If we even look at the first visual field machine, Andrew, those are big machines that we're looking into. And now we have like the headset, right? So over time, I think there is an evolution of, instrumentation where it could be better integrated and seamlessly into that workflow. So kind of exciting that I think it's a UK that has access to this, but I haven't seen this in the US, but again, excited that there's access to that for the practitioners out there.
Yeah, when I first looked at this announcement, I was like, "Okay, that's cool." But it's the standard of care thing, right? That's the element that really, as Andrew mentioned, and I love what you said, Priscilla. Like that's so true. When we would go to accounts to like work with a product, like, and you have to teach them how to do topography, and you're in this small space, and it's just like everybody's having to do this. That's definitely a key thing. And isn't it the TopCon Maya that already measures axial length and does topography, if I'm not mistaken? So this is not the first of its kind, but it does represent this move towards axial length as the standard of care. I guess my question is like 5 years from now, will it be possible to practice evidence-based myopia management without measuring axial length? Like, when does this become the standard of care? Because the reason why it hasn't is because obviously the cost involved with getting yet another piece of equipment, which this could potentially solve by bundling it together. And everyone says axial length is the standard of care. In my personal life, when parents say to me like, I'm interested in myopia management for my kid, what kind of questions should I be asking the office? I said, ask them if they measure axial length. That's the easiest way. If they don't, find somebody else. And if they do, here's some other things you can start to ask them. Keep it simple. Do they measure for axial length? It's the standard of care, or it will be very soon. So, when is that going to happen? Like, is that possible? What do you guys think?
Phew.
I'll let Andrew take it first.
Yeah, I'm not great with predictions. It's uh, I think it's coming pretty soon. I don't feel like I'm that old, but I remember having this conversation about OCT and glaucoma, and I think that probably more doctors than not felt that when I graduated from school, OCT was not the standard of care for glaucoma. Now I think 100% would say that it is, and I draw the parallel, but I think it's a little bit interesting too that these conditions are different. Um, there are absolutely eye doctors out there who say, I'm just not interested in glaucoma. If I ever find somebody who has glaucoma or I think they have glaucoma, I'm going to refer them out. I've never heard a single eye doctor say that about myopia. It's just too common, too prevalent. If you're referring out 50% of all your patients, you don't have a practice. And so I do think this is a little bit different. I think this kind of changes things where, even if OCT is standard of care for glaucoma, there are some practices that can still get away with not doing that because that's not what they do. I don't think people are going to be able to avoid this for myopia. I think it's coming. I think that the demographics are going to make it really tough to avoid much longer. I think that, again, the technology, the more options, the more competitive these are priced, you know, the more you do not have to be a specialist to bring this unit in, the more prevalent it's going to become. And I think that's a good thing, but I also think that it's got to be sooner rather than later. I don't think this is going to be 10 years. I think you're probably pretty close on that 5-year guess.
Hmm.
Um, but I've been wrong before many times, so we'll see.
Priscilla, what
I
do
was
you
going to
think?
say, I am not quite as optimistic, but I think it's because I've spent so much time in the myopia space, like kind of trying to influence doctors, right, to purchase the equipment, to do more. And I think it's a very similar comparison to when Ortho-K first became available, and there were doctors who were prescribing without owning a topographer in the clinic, and they were still doing that for many, many years. Like, I met an office that had done that for 15 years, right? Like, it was just one of those things where I'm like, oh my gosh, I don't know how you're doing it, but it's definitely not standard of care, right? So I think it takes a lot to move everybody towards that direction. So I'm a little less optimistic about it for that reason. But I would say that, if someone is serious about myopia management, then I think they can look at how do they pay off that instrument, right? From the practice economic standpoint, and how does that enhance their care, right? Like, not everyone can afford to buy an OCT, but you could work your way there. So I do think that eventually it's going to happen for those who are taking it very seriously, but I don't want to, I guess, scare off those who are trying to enter into the space who are not quite ready maybe to buy it as well,
Mhm.
because I know just specifically for my site, we actually have a very tight correlation with refractive error and axial length in the 6-year clinical study. So, I always tell doctors, I'm like, hey, even if you don't have one of these, I want you to still start prescribing, right? We don't want to wait for you to have all the pretty toys to start talking about it, right?
Right.
Have the conversation. No single vision is not enough. Like, just start doing something. And so, I think in some of the more recent large online Cs, we've included this poll, like, how many of you own an axial link? And I would say that percentage still lingers around like anywhere from 30 to 40%. So there's such a huge, significant portion of doctors who are still not ready, I guess, to make that move to buy that capital equipment to include into their workflow. And, it's okay. But, if I had to predict, I think it would take us more than 10 years. But maybe as there's more instrumentation, there's more public awareness, patients are asking for it. I think they can, there's pressure from all directions to get doctors to start changing, how they're prescribing.
Yeah.
And I think also, like, when I look at these instrumentation companies, like, for example, Topcon, like, they're now leaning into oculomics, like, how do we use retinal images to predict other parts of the healthcare, and I think a lot of these large HMOs, like, they're going to move in this direction, right? How do we use the eyes to screen for those 270 different diseases, systemic diseases we can identify through the eye, right? So there's more of a medical model to begin with. So I think as that model starts growing, myopia naturally as a disease will also start growing, right? But I think one of the biggest challenges, I think also with talking to doctors is that, they're not quite ready because I don't think patients will convert. They don't think there's enough of a demand to have that instrument in their office. But I think as more treatment become available, again, more awareness, they're going to realize that they are falling behind and patients may not be coming back, right? Most of us are maybe not tracking the loss of patients who go somewhere else and never come back, right? We just assume they moved, but maybe they're moving because you didn't offer myopia management in your clinic. And like Matt was saying, like, you weren't measuring axial length and they found out through one of these online forums that a doctor who should be doing this or is doing this should have one of these devices. So they're making that decision on which provider to go to based on the availability of that number or instrument. I think those are definitely things that we need to be considering for those who are serious about myopia management and have the myopia mindset.
So
I love it.
I would say a couple things about that. So your 30 or 40% that have a biometer in your polls, I would also point out that's not 30 or 40% of a representative sample of the industry. That is 30 or 40%
Mhm.
of the people who consider themselves myopia people who are attending the myopia CE and who choose to respond to that because they probably disproportionately have a favorable thing to say. And so really the true number is way lower. I don't know what it is, but way less than 30 or 40% of eye doctors have access to a
Absolutely.
biometer. But thankfully, I would also say that change doesn't happen linearly. There's a tipping point, and there are certainly some things that I could see happening. You know, if Luxottica now has their Stellest lenses out, and they want to sell those, and they decide that they're going to put a biometer in every Luxottica practice corporate location, well, now all of a sudden that changes everything because not only do all of those locations have them, now everyone who doesn't have them, it's an arms race, and that's a big problem if your competitor down the street has a major advantage that you don't have. And so I do think that whenever this happens, I think that things will tip much more quickly than they have been. But yeah, point taken. We're not close to where we need to be right now, and we shall see.
Andrew,
I think
as a oh,
absolutely.
go ahead.
I think when I was with you, Matthew, like I think Essilor Luxottica actually does have their own topographer plus optical biometer. It's the reskinned version of the Topcon Maya, but I think eventually as they're coming out with their Stellus 2.0 and you know building in like smart wearables as well, where you're having frames that can now look at compliance and lifestyle and those kind of things, like it is going to tip the scales for sure. And I think it is making a case for the timing, right, of when all of these corporate locations have access to some of these. But again, I think there's a movement towards that medical model. So I think it comes along with that explosive growth that can occur potentially. But we know they've tried it before. So we'll see what happens this time around. But I definitely see that that is a focus for them.
Yeah. Um, Andrew, real quick, or maybe we can't do this real quick. Maybe we should do this in a future episode. But like, as a private practice owner yourself, like, how did you rationalize getting a piece of equipment such as measuring for axial length? Like, because it is such a big obstacle. If there's anyone in our audience who's like, yeah, I just can't justify, you know, purchasing that equipment. Was there some way that you were able to justify that as far financially for the practice?
Yeah, that's a good question. I I don't want to give any advice that applies to me, but may or may not be within anyone else's comfort zone. But for me personally, it's all about used equipment. You do your research, you find out what is a good device. You don't need the newest, fanciest, flashiest thing, um, and you can get eh, basically. If I could get a room full of 5 used pieces of equipment, um, I will take that every single time over one brand new, bells and whistles machine out there. And so some of these things can be pretty affordable and you can always upgrade later. When you use it more or when your cash flow is better, you can always go back and upgrade. There's never a time when you're just stuck. Um, and so, yeah, I actually don't think a lot of people realize, that that's even an option. Certainly there's some risk there. If you buy a used piece of equipment without a warranty, you need to know what you're getting into if it breaks down. But I think if you're intelligent about that, and if you do your research, do your homework, you're a little bit patient, looking for what you need. I actually think that many of these things, including a biometer, can be obtained um, much more inexpensively than a lot of people realize.
Mhm. Yeah, I
And I
mean,
would encourage a lot of private practice doctors to go talk to those reps, ask how much it costs. Cause, I think in our last role, Matt, we would go around talking to doctors. And oftentimes when I talk to doctors about, equipment and how much the range it can cost, they're always like surprised or like, wait, I thought this cost like whatever outrageous number because they have done minimal research in this space and they just assume that it's going to cost a lot of money to purchase one of these devices. So I totally echo, what Andrew's saying is look at used equipment, look at who's willing to donate. Because when I was in practice and building a myopia management clinic, there was a retiring ophthalmologist who was more than happy to donate his IOL master to us. Obviously,
Wow.
he had way more bells and whistles than what we needed, and it was a big device, but we happily rolled that device around to the rooms, right, to do what we needed to do because it had the instrument. It gave us what we needed, the measurement, right? But I would say, start somewhere, start researching, have a number in mind so that you can at least work towards it, right? If you never do that minimal work of looking at a number and setting a goal to get there, right? Or how does it physically make sense for you? Like how many patients do you need to see and things like that. And you don't do that math, then it's very easy to be like, wow, I don't think I can afford this. I can't pay this off. But as we were saying, you have a ton of myopes in your clinic. And if buying this instrumentation is going to help increase your conversion by 60%, that's going to pay for itself really quickly, right? And I think it's similar to, what we see in our profession, the rise of everyone owning a RF machine or IPL machine. I was like, those are not cheap. Those are even arguably more expensive than an optical biometer and topographer combo. But a lot of people are figuring out how to finance it, right? Because they see the vision of what it looks like to build aesthetic/dry eyes into their practice. I think it's very similar. The way we need to be viewing having some of these instrumentation for a myopia management clinic is do the math, figure out how to get there and plan for it, right? And sometimes your reps for some of these contact lens companies can help you kind of do the math, right? Or your business consultant can do that as well. Or the rep companies, I'm sure, more than happy to help you figure that out.
Well, actually, if it's okay, I'd like to add one more thing that I've tried to work on. Maybe there just is no solution to this, but hypothetically, it should work perfectly. And that is get out and talk to your colleagues. And I have tried to expand my radius. Practice is close to here. I am totally fine with doing testing only. If my friend and colleague down the road wants to do myopia management, does do myopia management, but they don't have a biometer, send them over. They can do a test in our office, twice a year, 4 times a year, whatever they want. We'll charge them for the test, but we're going to give that patient right back to you. We don't want to take anybody from you. And now everybody benefits because you get the data that you want. You get to keep your patient. Everyone has more access to this stuff, and it helps me pay off my biometer, to do those things. And so, um, ODs are, I think, a jealous, protective bunch, and we're not going to solve that anytime soon. But that option is out there, and certainly, Matt. Actually, if you have anybody that you know of that has successfully done something like that, or structured a really nice co-management or testing agreement between ODs that everyone actually gets on board with, that would be one of the most beneficial things I could possibly listen to. I don't know if it's out there. I don't know if it's being done successfully, but you'd have to think that somebody's bright enough to make it work. And I just think that would benefit everybody because now um, the whole point is out because you don't have to buy a biometer. You just say, "Hey, patient, I'm going to see you for your 4 visits a year here, but I want you to go to this other clinic, every 6 months to get your 20-minute axial length test done, and we'll collect the data from them." So that option's out there too. I'd love to see that utilized more. I'd love to have somebody in the area that has an IPL machine. To your point, Priscilla, if I had somebody close by that I could refer out for IPL and RF and all these things that I don't want to buy, um, sign me up.
Yeah. Well said, both of you. Um, that'll do it for our first 3 topics for this episode. We're going to tackle a 4th topic, which is going to be available to our paid subscribers, and that'll be coming out later this week. So if you've loved this episode, if this episode has been useful to you, please consider becoming a paid subscriber on our Substack, the cost of which is just $12 a month, which is basically the cost of a cup of coffee each and every week. And I say, hey, if you would buy Matthew Herzberg a cup of coffee to have on amazing guests and to talk about these news stories and really digest them and break them down for you, then by all means, consider supporting us. MyopiaMindset.substack.com is how you do so. All right, Andrew and Priscilla, let's move
Well,
on
actually,
to
last
our
thing to before your unpaid people
sure.
hop off. This
Yeah.
last one that we're going to talk about, I think, is really cool. So subscribe. Like we didn't front load these. The really cool thing that you can take to your practice and your business right now. That's what we're going to be talking about right now. So like subscribe. Yeah,
Let's do a cliffhanger.
let's do it.
What is our fourth topic, Andrew?
I don't know. Can we tell them?
Yeah, we could.
Oh,
We're going to be talking about Myopia Focus, which is a digital platform that can put a suite of uh, like tools on your website to help your patients navigate these like really important questions for your practice. And I think this is a great topic, and I'm looking forward to breaking it down with y'all. Priscilla, thank you so much for joining us. I can't wait to have you back on. I wanted to what if anyone has any questions for you or wants to know more information.
Well, for me specifically, if you can find me on LinkedIn, I'm under Priscilla Chang. The hyperlink is Priscilla WCHANG.
Awesome. And Andrew, same for you. If anybody wants to know more information about you and what you're doing, how can they get in touch with you on the internet?
Yeah, just email at c@icaredupage.com. And well, and also, Matt, maybe you would be the perfect person to do this. One thing that I always thought would be fantastic would be a um, a sub meeting at Vision by Design, rent a side room with a bar where everyone has like a 3-drink minimum and then just
Uh-huh.
argues about this stuff. That's when you really learn stuff, is when you start arguing. And so, we didn't come up with anything too controversial or anything to argue too much about today. But
Are you sure?
um,
I said this guy's thing he said was offensive.
uh, let's explore
I
that.
thought it
Let's
was.
explore that over bourbon or three. Yeah.
No, I'm sorry to interrupt. Go ahead.
No, that was it.
So
Myopia
what you're talking
mindset.
about is like a meetup at Vision by Design. Is that what
Yeah.
you're describing?
Yeah.
All right. Yeah. I mean, I will put that to the subscribers. We are building a little bit of a community here on Substack. If you want to hang out at Vision by Design, if you're going to be at the Super Bowl of Myopia Management, I'm certainly going to be there. Let us know in the comments or send me an email or wherever you found this. Myopiamindset@gmail.com is the email address. And let us know if you'd be interested in that. If we get enough people together, then we'll see what we can do. It'd be great for everybody to meet and talk and go over some of these topics and maybe we could hash out some particular hot takes and issues, or maybe we'll all just agree and have some drinks and have a good time. I don't know. Either way, it'll be
Maybe.
awesome. All right.
Yes, register if you haven't to the Super Bowl of myopia management.
That's right. All right. Well, Andrew, Priscilla, thank you again for coming on, and for everybody else, we will see you at the next one.